When someone starts dialysis, we look at dialysis as a stepping stone, a bridge to the best care of that end-stage renal disease patient, which would be kidney transplantation. There is research going on in terms of artificially made kidneys. I think that that is still several years away. So for the time being, the treatment options for patients are the modalities of dialysis that are available, and this being primarily viewed for those who qualify as a bridge to the best therapy, which is kidney transplantation. The answer is probably not. Okay, they're supposed to be. The way that dialysis units are viewed, or there are certain metrics that all dialysis units have to or are scored by in the United States. There are many metrics that are used to evaluate the quality of a dialysis unit. So in any kind of system where you try to measure those quality metrics, someone is going to be on the top and someone might be on the bottom. Does that mean that dialysis unit who has what we call an ultra score that's lower than someone who's higher provides inadequate or less quality care? The answer is maybe not in a lot of those circumstances. But there are very different nuances that different dialysis units have. We've been one of the most measured areas in medicine in terms of end-stage renal disease in the United States. There are quality metrics that we have been evaluating for the last 20 plus years. But I only bring up the caveats that when you measure certain quality metrics, it also is in part dependent on the quality of the patient who is admitted to a dialysis unit, in which we oftentimes will admit anyone who wants to be on dialysis and who we deem as an appropriate candidate, even if they're extremely ill. So therefore, if you take patients, for example, who are on dialysis who have metastatic cancer, their life expectancy is going to be a lot less than someone who is young and waiting for kidney transplantation. As such, your quality metrics in that unit may be not as high as someone else's dialysis unit, but that does not mean that you don't provide utmost top quality care. But it is measured, and quality metrics are prevalent throughout our subspecialty. There are several tools that we have to lower and improve patients' blood pressure on dialysis. The first thing that we look at is how much weight do they gain in between dialysis sessions. So the amount of fluid that patients generally gain in between a 2-day dialysis session will often affect their blood pressure. And so the first thing that we do is we have dietitians review the dietary restrictions with the patient. So dietary restriction is the first treatment option that we have. Adherence to that dietary restriction is continually counseled in our patients. And obviously then for the majority of patients, there are 90% of our patients are on antihypertensive medications, and we work very closely with both the patients, their other areas of subspecialty, in formulating the best antihypertensive regimen that's available for that patient, with the least side effect profile obviously possible. But 90% of our patients are on blood pressure medications. We continually need to adjust those medications. We oftentimes tell our patients to take their blood pressure on non-dialysis days, which is also another metric of where and how we should adjust their antihypertensive medications. Our patients, the cardiovascular disease, not just high blood pressure, is a major cause of death in our dialysis population, and therefore we work very closely with the cardiology services to address their other cardiovascular comorbidities and not just hypertension. Hepatitis C is one of those diseases that we screen every single dialysis patient who initiates dialysis, and we screen them for the possibility that they're infected and not knowing, which is the majority of patients. We screen every single patient with liver tests, which helps aid in the diagnosis. But more excitingly than ever, it was just a new medication was just recently approved for the treatment of hepatitis C in dialysis patients. There are other medicines that have been approved and used in the treatment of hepatitis C in dialysis patients. However, oftentimes they have a lot of toxicities associated with them, and sometimes these older medicines could not be used in our dialysis patients, and the newer medication now that's been approved will be used, and there's a national screening program that's going to occur to screen just about every single dialysis patient in the United States. We here at Hackensack University Medical Center already do this for every patient that comes into our dialysis clinic, and every patient that comes into the hospital who requires dialysis. They're screened not only for hepatitis C, but hepatitis B as well. In addition to that, we use universal precautions amongst the nursing staff and the staff that care for these patients, and we make every attempt, obviously, to prevent the transmission of hepatitis C amongst patients in a dialysis facility. We have made a major push here at Hackensack University Medical Center also to decrease the dialysis catheters, which are one of the major reasons, and it's felt that hepatitis C has been transmitted in certain dialysis populations and communities. And we at our institution have made a strong push in eliminating these catheters to the greatest possibility that we can, so that we use the AV fistulas in the arms of patients, which has been shown to have a less of a risk of transmission of hepatitis C. There are many different avenues that we use here in our institution to prevent the transmission of hepatitis.